On today's episode of the Telehealth Heroes podcast, I get to welcome Dr. David Moe, who is a Chief Medical Officer of Get Cerebral, to the episode. And if you guys have watched TV lately, you've seen these commercials about Get Cerebral. And so it's exciting to have Dr. Moe join us. And I'm very proud to say that Get Cerebral are huge Doximity users, among our top users in the company. And so it's thrilling to be able to talk to one of the leaders of Get Cerebral. So, Dr. Moe, welcome to the show today.
Thank you. Thanks, Brandon, and thanks for having me. What you guys are doing at Doxy is really enabling telehealth to take off. So we have you to thank for that.
Oh, definitely. It's teamwork, right? It takes we provide the tools, but it's companies like yours that take it to the people. So tell us a little bit about Get Cerebral and the problem that you are solving.
Yeah, absolutely. So I'm a psychiatrist, data scientist by training, and I have to say that the mental health system is completely broken. Right now, the status quo, if you want to see a psychiatrist, you look up your directory if you are lucky enough to have insurance, and you have a list of all these different clinicians you can call. You call them, and the average wait time to see a clinician is 2 to 3 months. Right? So you're severely depressed, and you have to wait months before that happens. Then you say, maybe I want a therapist, and when you have to find a different directory, call the therapist, and wait 6 to 8 weeks to find a therapist. Very importantly, the therapist and the psychiatrist never talk to each other. They don't coordinate care. They don't measure outcomes. For over 90% of our mental health professionals do not measure outcomes on a systematic basis. And so that's just a broken system. And telehealth has completely changed that. Because now what we do is, first of all, we make sure that access is very good. When patients come onto our website, they could find a clinician within 2 days. And not only that, this is a clinician specifically matched to them. So if they come in and let's say they want an African-American therapist who's female, who has, let's say, experience in trauma-informed care, we can honor that because we have over 2,000 clinicians in all 50 states, right? So they're able to be matched to a better clinician, and then they're able to see that clinician within days instead of months. And that's real value there. On the other side, we measure outcomes. So over 80% of our patients fill out these clinical surveys on a regular basis, and we're able to track how they're getting better or not getting better, and then adjust the level of care depending on that. And so all of that has allowed us to become literally the fastest growing healthcare company ever. Within 2 years, around 21 months, we were able to go from 0 patients to 200,000 patients in all 50 states and the UK. And we are launching a number of different operations that I'm happy to talk about that are pretty unique to mental health. But we are closing a $300 million round in the coming weeks, and we're hoping to become the global leader in telemental health.
David, you have a background in psychology. How did you get connected to Get Cerebral, and what made you make the decision to jump and become the CMO there?
Yeah, it's a great question, Brandon. So I was actually running my own telepsychiatry company previous to this, and it was going very well. That company, Valera, we just closed a round prior to me leaving, and it was growing very, very quickly. As a matter of fact, they just closed another round a few weeks ago. So I was not intent on leaving. But when I met the Cerebral team, there was something very, very special about it. Their commitment to outcomes was just second to none. And I really trusted my CEO when he said, look, I'm going to give you the reins over clinical quality. And if that means it's going to be expensive, there's going to be resources that are needed, I'm going to let you run that. And that's hard to do because if you think I would say a lot of our competitors really focus on that scaling piece, and they don't focus as much on the quality piece, right? So I thought it was an opportunity to really transform mental health care at scale in a way that I wasn't able to do previously, or at a smaller scale, I would say. And so that was an opportunity I could not pass by. And since I've joined, it's one of the best decisions I've made in my life. And we've been able to redefine what high quality mental health care is, and hopefully continue to do that going forward.
Do you still see patients today?
Unfortunately, no.
Yeah.
I used to see patients on the weekends and in the evenings, but this is the fastest growing healthcare company ever, and that requires
I
90
mean,
to 100 hours of work a week, and I
yeah.
just couldn't do it.
In a way though, it's like you can see one patient, you can spend an hour seeing one patient, or you can spend that same hour improving a process that will improve the quality of thousands of patients. And, in a way you are still seeing patients, you're just doing it at a larger scale.
That's right. And I would say I do miss it. I really enjoy seeing patients. I actually do something that probably not the best use of my time, but I enjoy it so much. So I actually have a clinical office hour where people will come and present cases, and we would talk about cases. And it's, we have a lot of these educational, they're all free, these sessions for our clinicians. And it's one of my favorite, times of the week to sit down and just talk about patients and see how we can help them and then get updates on them.
Oh, that's fantastic. You are well on your way. Now, what you're proposing, it's probably been done before, and other people have tried to do it. What do you think Get Cerebral has done that's made it successful and the others haven't been as successful?
Yeah, it's a great question. So I think a couple of things. One is the focus on quality. If you look at how other telehealth services work, they focus on scaling. They focus on access, getting access to care. And these are both important things, don't get me wrong. But if you just focus on those two, you're not going to focus on quality, and the outcomes are not going to be really there. And what ends up happening is that the insurance companies look at it, and they're not going to be very impressed, right? They're not going to really want to work with you, right? Employers are going to look at it, and they're not really going to be impressed either, and they don't want to work with you, right? So institutions will not work with you. So they are solving a problem, but they're not solving at the right level. So if you think about this, just Google top telemental health companies and look at their chief medical officers. Most of them are not even psychiatrists. It's very, very interesting. And it just tells you how little they prioritize the clinical side of things and how much they prioritize the other side, the growth side of things, right? So that's one major thing. We really focus on quality in a level that others do not. We publish papers on this. We're actually running a quality study on suicidal ideation right now in conjunction with one of the largest insurance companies in the country. When we showed our data, this is an example of when you focus on quality, the other doors it can open. We had a sit-down meeting with the chair of the National Health Services in the UK, and he was so blown away by our outcomes that he's helping us break into the UK, and we won our first NHS grant recently. So when you focus on quality, there are many, many other opportunities that begin to open up. Maybe I'll name one more, which is that where our data infrastructure is so good that we were approached by pharmaceutical companies to run clinical trials. So in a couple of weeks, we'll be doing that. We'll be developing new treatments for pharmaceutical companies for depression and anxiety and things along those lines. And once you have the quality piece, a lot of those others fall in place. The second piece is operations, and I think it's not sexy. People don't like to talk about it. It's not interesting, but it's critical. And we have really the best operating team I've ever seen. And I've been in a lot of startups, seen a lot of operators, and we really focus on outcomes. We focus on OKRs. We hold each other to it. We set very aspirational OKRs, but for the most part, we do get them.
That's fantastic. I'm curious about this quality. So I get you guys focus on quality, but what does quality mean from the perspective of the patient? What do they notice about Get Cerebral that they won't experience with other companies?
Yeah, a couple of things about quality. One, from the patient perspective, there's the UX. It just has to be super simple, and they're able to do that, right? So think about the experience here, right? You go online, you either download the app, fill out a 5-minute survey, immediately you're matched with a clinician. At any point you want to cancel appointments, you don't have to jump on the phone. You just text it and they reschedule appointments, right? Very, very simple. You can get your appointment through the phone or on the web. So the UX is very, very easily done and conducive to people engaging in care. And if they don't fill out a survey, we could just send them a brief message saying, hey, can you fill out the survey? It's really important for us to understand how you're doing, right? So that drives a lot of adherence. It drives a lot of quality as a result of that. Other metrics that are really important. So for every mental illness, there is a validated scale, validated clinical scale, and we follow this, right? So for depression, it's the PHQ-9, the one that a lot of people are familiar with. But for others, there are many others as well. So for anxiety disorders, it's the G87, ADHD, the ASRS, et cetera, et cetera. And based on the patient's diagnosis, we would follow those scales on a monthly basis going forward. The one other metric that's really important, and it's commonly glossed over, which is very strange to me, it's medication adherence. So if you actually look at medication fill rates, so of all of the psychiatrist patients who get prescribed some medication, what percentage of them actually fill the medications? It's 50 to 70%.
Yeah.
That's pretty alarming. Just think about that. These are patients who see their psychiatrist, say, oh yeah, doc, I'll fill the medication. And they continue to see their psychiatrist, but only half of them, a little bit more than half of them, will actually ever fill their medication. That's scary.
Let alone even take it. They might fill it and not even take it, right? So
exactly.
Yeah.
So you wonder why depression care has been so poor in this country, right? And it's not just the U.S., it's across the world. So what we do when we realize that, hey, we have to drive quality up. If we prescribe the medication they're just not taking, what's the point? What is the point, right? And so what we do is we actually have our own pharmacies and our own partner pharmacies, and we ship those meds directly to patients' homes. And our adherence rate to the fill rates for medications is 94%. So that's industry leading, and part of the reason that we're able to drive industry leading clinical outcomes, I think, is because we're able to drive adherence to those medications.
And it seems like you drive adherence and adoption and utilization just by making it easy as possible for the patient. Like, you don't really have to do much. Just show up. We'll do this. We'll fill out this form, but it's part of the experience. We'll ship the drugs to you. It's taken that burden and the onus off of the patient and just giving it to them, and lo and behold, they will do it if it's easier to use.
Absolutely, yeah. So think about it this way. If you have diabetes, you go and see your endocrinologist, see a doctor who specializes in that. You've got the motivation to do that. They tell you things and you understand it, right? You're able to go to the hospital, find parking, walk to the clinic, right? Wait in line, and then wait half an hour, because American doctors, that's what we do, right? We make our patients wait, right?
Yeah.
If you have depression or anxiety, that's much, much, much harder, right? If you're depressed to begin with, one of the major symptoms is amotivation. You don't have the motivation to do things. If you have an anxiety disorder, and the whole reason that you need to seek help is because you don't want to be in crowds, are you going to sit in a waiting room with other patients?
Or
no,
a busy bus or subway or something? Yeah.
Exactly. Yeah. So this is, I think the whole system has been very catered towards the clinicians. It's been designed for the clinicians, and it may work for other specialties at some level, but it certainly does not work for behavioral health. And this is where I think telehealth really transforms the service, because it opens a lot of ways for patients to engage, and it makes it much, much, much simpler. I'm not talking about a little bit, right? This is a game changer in terms of how things are thought through. So I think that's a major thing. I'll give you a couple of examples that I think are really interesting. 65% of our patients have never met a mental health professional beforehand. And I was alarmed by that. I said, wow, that's ridiculous. And I started asking the patients, well, what happens? Well, they say, look, I live in a rural area. The city is an hour and a half, 2 hours away. I can't afford to take an afternoon off every week in order to go get therapy, so I don't. But I know I need it, and I really want it, and it's been very helpful, right? So the distance has been basically not a non-issue with telehealth. Here's another one, and we should completely destigmatize mental health. I get that. We can't avoid the fact that stigma is still there. Right. So we have patients. This is very jarring for me, and really changed how I think about this. We had a patient who kept on showing up on therapy appointments in his car. He's just driving around, and we're thinking, I remember the therapist calling me up and said, "Hey, is this okay?" And I said, "No, it's not okay. You can't do that. We might be talking about very serious things, and he's driving. And so I said, yeah, tell him, like, look, it's this. He has to be in a quiet space. He can't be driving. We don't want to put him at risk. If we're talking about past trauma, things like this lines." And then the patient said, I don't want to tell my wife that I'm seeing a therapist. I don't have an office at work. And so the only way I can do this, the only way I can get help is by driving around the block. And so your choice is to either help me get help this way and adapt your systems to me, or force me to give up help and not have help. And that completely reframed it for me, because there are these people for whom stigma is still a very big problem. But for that reason, we should not limit help to them. So after that, we made our framework much more flexible so that we're able to do some of these things. And I think at the end of the day, what really matters is clinical outcomes, not some principle that we've created 100 years ago that we want to, you have to lie on the couch, and if there's not a couch, no therapy, right? We don't want to do that kind of thing.
Yeah. And it's really, the focus is on the patient, right? It's not about the provider and the healthcare system or the payers. It's about, what does the patient need? What does the patient want? And how can we get them what they want as simply and easily as possible? And it certainly sounds like you guys have nailed that, so kudos to you guys. And so you guys started in January of 2020. Is that correct? And
yes.
If everybody wants to roll back their time warp, January of 2020 was 2 months before COVID hit the United States. It was already hitting in overseas. How did COVID influence the meteoric rise of Get Cerebral, and what would have happened if COVID wasn't here? Would you have still seen the uprise, or would it have gone slower? Tell us how COVID had an impact on your growth.
Yeah, very frankly, the answer to your question is no. We wouldn't have seen that kind of rise. I think it would have been a good business, but valued at many billions, no chance. Within 2 years, no chance. So here's the interesting thing about COVID. There are some silver linings for COVID. One of them is that telehealth has been taken as a norm. So here's a really fascinating thing, and it just blows my mind. When academics study a specific intervention, let's say telehealth, and they show that it's valuable and it works and it's just as good, if not better, it usually takes 15 to 20 years before it actually trickles down to actual practice. That's ridiculous to me. Yeah. And this is actually true across all fields of medicine.
Yep.
Right? That interface is 15 to 20 years, and that's just outrageous to me. COVID changed people's mind very quickly. So just some stats here. Before COVID, 90% of mental health professionals never used telehealth. Right? Right after COVID, within 3 months, 90% of clinicians were using telehealth. Yes, right? Yeah. Those who didn't retired. Right. Yeah. So the idea here is that it was a real catalyst to unlock all of this clinical capacity and make telehealth normal. Right. So I think that was a major driver, certainly. The other thing I would say is, the advent of Zoom and DoxyMe and companies like this have made this more normal. Right. Mm-hmm. It used to be weird. I don't think people think about this. Just 2 years ago, 3 years ago, to be on a video call was weird. A call is something without video is kind of the idea, right? And now, so the norms are changing, and so this is becoming less and less weird to patients, and that also is a major tailwind for the market.
Mm-hmm. How do patients find Get Cerebral?
Yeah, good question. So we certainly advertise. So you probably saw that Simone Biles is our Chief Impact Officer. Maybe a word on that too.
Sure.
Simone really had the pick of the litter. Over, I think, 20 mental health companies were trying to get to her. And why did she choose us? It was actually because of our quality. Right. She's actually a patient of ours. And she is very well supported, and she just loves the fact that things are measured and things are convenient, and she's on the move all the time, and we make it really, really convenient for her. So that's been very, very helpful, and she is just such a fantastic human being. Having spoken to her mother now a few times, they're just so mission driven, so humble, and so willing to take risks in order to help other people. We've actually had patients say, I'm here because if someone like Simone can say that they have a mental illness, I could do it too. Right. If someone that powerful, that strong, that goatish can do this, it's not weakness. This is actually a strength to have, to be able to understand your own vulnerabilities. Mm-hmm. So certainly, to answer your question, Marketing is certainly a very large piece of what we do. And otherwise, word of mouth travels very, very far. A lot of our patients are actually recommended by other patients. And the last thing I'll say is like we're beginning to publish more of our outcomes with insurance companies and whatnot. And so some insurance companies look at our outcomes and they say, "Wow, that's really interesting. We want to make you a preferred provider, and so we want to steer patients directly your way." And so for some insurance companies, literally when they look up mental health, instead of that directory I was telling you about where they have to call those numbers, the first thing that shows up is Cerebral. And they could just go and get care that way, and we take insurance as well, right? So these are the ways in which we've been able to get the word out.
So you've got Simone as your Chief Impact Officer, and she's going to take this effort to help destigmatize mental health care. What else is it going to take to help healthcare become further destigmatized?
Yeah, it's a good question. So it's that principle, right, where you take someone who is a role model, who is strong, who is the top of his or her game, and for them to show that vulnerability, that's what it takes. So what does that mean? That means the best athletes in every sport. It means the CEOs of the most successful companies. It means the most successful entrepreneurs. And when it becomes clear that these high-performing people are taking time for their mental wellness, that's going to destigmatize in a way that's very, very different. So we were talking to some employers. So we do work with companies as well. And the biggest difference, whether it works or not for a company, the engagement rate for a service like Cerebral, is whether the CEO is involved or whether someone in the C-level is involved and says this is important and shares a story and mentions this, because everyone is, there's a stigma there already. They don't want to seem weak, but when someone who they respect and they want to emulate demonstrate this, it changes everything. So, my hope here is that another thin silver lining of COVID is that it really destigmatized mental illness in a big way. We still have a ways to go, but I think we're definitely headed in the right direction.
The other thing is there was a lot of stigma with going into a psychiatric unit at a hospital and walking into that and having that feeling of, I'm not crazy, what am I doing here, right? But that's going into a physical location. But if you can go and get the care you need, well, not have to go. The care comes to you in the privacy of your own home and nobody else knows about it. There's no stigma to worry about at that point, because the whole stress of going into that environment, being seen, by a neighbor at the unit, it's vanished at this point.
100%. Yeah. So this really allows it, and you begin to compare it with other things like, I use Peloton, right? And I have a fitness buddy, right? And I see a therapist, right? Yeah. These are things for your self-care, right? And so the equivalency becomes very different. It's no longer compared to, I had to get my colonoscopy, or I had to go see my primary care doctor, and I had to see my psychiatrist, right? It becomes a much more normative thing to say, hey, that's normal, right? And so the other thing I'll say about this is, and I know this is a little bit controversial, but I think mental illness is becomes a priority for wealthy countries, right? Because once if you go to a place where healthcare systems are really shoddy, I wouldn't say the first thing you want to do is focus on psychiatry. Right, you want to focus on infectious disease. You want to focus on surgeons who can fix broken legs, right? And then eventually, once you have those set up, then you want to focus on psychiatry. People deserve to feel better. They deserve to have the right to be more productive, right? So, I can understand why this has taken a while to really destigmatize. But if you look at the wealthiest cities in the country, for example, it's a joke in New York City. Hey, who's your therapist? Right? People just talk about it. It becomes a very normative thing to talk about. So I'm optimistic that we're going to get there, but it's going to take some time.
Mm-hmm. And it's going to, like you said, the wealthy countries, this mental health is probably the top 1, 2, or 3 issues that Americans are facing today. But you're right. You go to a third world country, and those mental health issues still exist there, but they're just not killing people the same way that infectious diseases are, or other diseases that have been eradicated 30, 40 years ago are killing people. But eventually, when those things get taken care of, Well, guess what? That mental health is still there. It still exists today. It is going to become a number one issue. And so why not provide it, make it available to everyone?
100%. Completely agree with you.
What percentage of your patients have never had mental health care before and likely wouldn't have got mental health care if it wasn't for Get Cerebral?
100%. Yeah, great question. So we have very, very clear numbers. 65%. 65%
Wow.
of the patients here, the way I put it is, never had the privilege of accessing mental health care. And these are people that maybe they can't afford to drive in for an hour appointment. Even if they have insurance, they can't really do it. And so, a big part of our mission is democratizing mental health care. It should not be a privilege. It's healthcare, and we should be able to provide people with it. People deserve to be able to be happy, especially those who are really wanting to find techniques and discover ways where they can better themselves. The same way that we say people should go to the gym, people should really focus on their mental health as well in the same way. And so that's a big piece of that.
Mm-hmm. Now, in order to support all these patients that you have coming in, you've got to have great providers. What is your process of going out and finding the best providers and getting them to have the quality, the standard quality that you have, that you want to maintain, that quality of great care? What is that process, and who do you look for, and what type of training do you provide to make sure that the providers are top-notch to meet your criteria?
Yeah, great question. So certainly when they come in, there's an interview process and a training process to see where people are. A lot of our great clinicians, a sizable minority of our clinicians are actually referred in by other clinicians because they enjoy working with us so much. Once they're in, and I would say this is one of the most innovative features of Cerebral, we have an internal quality program like no one else. So every month, every clinician is required to sit down and look at their data report. It's a personalized data report. It shows them all of their patients by depression, anxiety, whatnot, and how they're doing. This score was here, now it's here. There's a list of patients that are at high risk because their scores are very high. Their depression scores are very high. And the idea is this is an actionable piece of data. Go after them. Go talk to them. Set up another appointment with them. Maybe change the medication. Maybe the dosage isn't correct, right? In addition to that, we have other metrics that are very helpful. So we audit their charts every once in a while, and we send back the feedback from other doctors. It's all there. We also provide anonymous feedback from other patients, right? So patients can write feedback and give a star rating for their clinicians. And so all of that data is in one simple report. Every clinician is required to sit down and look at the report and do better. And we have a paper actually that shows that month on month, our clinicians, do get better by a sizable amount, right? So the idea here, Brandon, is to really create a continuous learning process for clinicians. It's something very counterintuitive for all of healthcare, not just mental health care, to have really direct feedback. And the reason is because no one measures outcomes, so it's very hard to provide feedback. But because we do, we're able to build this continuous learning system that keeps on improving the quality of care more and more.
Now, with you mentioned that the patients provide feedback and they take surveys and whatnot. Is it the same provider that meets with the same patient continually and they've developed this relationship long term?
Yeah. So that's a big part of it, right? That strength of therapeutic alliance is really important. Right, so we actually care about longevity. Adherence to care is what we call it, right? So does a patient stay with them? Because we actually make it such that patients could request a different therapist or a different prescriber if they want. We make that pretty frictionless, actually. But the idea here is that we don't want that to happen, right? If you're a good clinician, your adherence should be high. Your adherence rate should be very high. And so what we do is every month we have a metric of the month, and this is like a quality metric that we say is important. And we actually give gifts to people if they are top performers. And so the idea here is that we're urging this is the very rudimentary versions of pay for performance.
Now, so if I'm a provider and I have my scorecard or report card and I see a patient that's just not getting better, do I have the initiative to go and follow up with that patient, even though the patient's not asking for it? Do I still have that drive, the initiative to go help that patient proactively?
Yeah, I mean, I think that is the idea to be proactive here. And now, the challenge of being proactive in mental health is you never knew when your patients weren't doing well. You just never had the data, right? So if you're, let's say, a prescriber, you see your patient once a month, once every 2 months, they're suicidal 2 weeks after your visit.
Yeah.
How do you know? They're not going to call you and leave you a voicemail. They're not going to text you, right? So you just don't know, and then you find out after the fact, right? But we have that data now. And we're able to arm our clinicians with that data so they can walk into appointments and they can be proactive about reaching out and talking about issues. So it really changes the treatment model to optimize for the patient outcomes.
So obviously the patients are incentivized they're paying for this, or incentivized to get better. Are there other incentives that you guys use to help engage patients and keep them coming back so that they keep coming back and keep subscribing to the service?
Yeah, so I think the best way to do it is just to provide high quality care. Mm-hmm. And patients recognize it. If you look at our star ratings, 4.7 out of 5, because patients come in, they're sick, they're depressed. Yeah. They lost their mother to COVID. They're anxious. They're not in a good spot. And when we really hold them and help them out, they get better, and they see that it's a very strong emotional thing when you get better, and then for them it's very clear, and they'll send us messages and say, this is fantastic. Mm-hmm. One thing that we do is that we do monitor patients even when they, let's say, leave. Like we say, hey, you can come back at any point, because mental illness is not one of these things where it's not like an infection.
Right.
You treat it, done, you don't have to worry about it ever again. It's something that comes and goes. Some people, for example, during the winter, their mood gets a little bit worse, right? And then during the spring, they're fine, right? So for those people, they come in during the winter, they leave during the spring, and that's perfectly fine. We can adapt our care based on that, right? So, but patients are, very, the way we encourage patients to stay with us is just to unite behind the quality piece.
Right. And focus on them, because there are times where they have an acute episode and they're struggling after a death of a family member, or it's a winter, but they don't need that same level of care year long or in perpetuity, but it's just you adapt your service up and down according to what the patient needs.
Exactly. Mm-hmm. That's exactly the way you said it. It was perfect. So we titrate the level of care based on the need of the patient. So, for example, let's say someone lost their mother to COVID, and it was a traumatic experience. They have PTSD, so at the beginning they use weekly therapy and medication management, so on a regular basis. Let's say it's 6 months later, they're better. They've learned coping techniques through the therapist. They're on good medications. They probably don't need to see their prescriber once a month, once every 2 months. That could be once every 3 months even, right? Therapy, they could take a pause from the therapy side. And if things get worse, let's say it's the anniversary of the event and things are getting worse, they can always come back and say, look, I need that therapy again, right? So the idea here is that we don't want to, again, make the system work for the clinicians. We want it to work for the patients. And maybe a word about that. You might ask, well, why isn't that the case? That just makes too much sense. Why isn't that the status quo? The frank truth of this is that the business of mental health, it's better just to keep patients on for indefinite therapy.
Yeah.
You just get paid more. You don't have to see new patients. Insurance paying for it, or they're paying for it. What do you care? Why do you need to see new patients? You don't want to create more work for yourself. Right. So that's a real problem, right? So there's a monetary incentive against stopping care, right? And that's what clogs up all of our mental health professionals. They have their panels, and they're not going to pick up new patients. They have no incentive to do that, right? So for us, if your North Star is clinical quality, you do have an incentive to do that, right? And that's why we're so focused on that piece.
It really is a perverse incentive, because your measure of success is them getting better, and if them getting better means they don't need you anymore, means you're out of a job. So in some way, your measure of success is putting yourself out of a job, in conceptually, but in reality, it just shows that you're effective, which brings more people in. So while some people graduate from the program, it shows that you're effective, and other people will come in and fill those holes. Yeah,
and Brandon, I'll say this, in 50 years, 20 years, I don't know what it is, I'd be happy to be out of a job if mental illness is eradicated.
There's no more mental health issues, right?
That's a great thing.
Yeah.
I don't know what I have to put in the water to make that happen, but I'd be very elated for that to be the case. Right now, we're very much far on the other side of the spectrum. Like 18% of all human beings have mental illness, and a tiny fraction of that, tiny fraction of that, are getting the treatment they need. Right, so less than 2% are actually getting the treatment they need. Right, let's get them to care. Let's get these people to care. And one day I hope that we could get so good with preventative mental health care that we don't need this service. Right. But I think that's probably going to take a little bit of time.
So in just 2 years, you've grown to how many providers do you have now?
Around 2,000.
So 2,000 providers. Where were those providers 2 years ago? Were they in other practices, or were they just graduates, or were they working at big hospitals? Where were they before, and what did they leave to come to you?
Yeah, all of the above. And what's interesting is that we were talking about how before COVID only 10% of people used telehealth, and now 90% of clinicians use telehealth, right? So they all had to go on telehealth. This was a brave new world, and so they talk to each other. What's a good experience? What's a good place? And we're one of the top places to work for. And so they come, and a lot of them are, still have hospital shifts. Some of them are part-time, and others are seasoned therapists who just want to fill their panel. They may have, 80% filled, and they just want to fill out the rest. And others are full-time with us, and they like the flexibility. They could travel the world, travel the country as they're doing their clinical care and working. So it really is a wide range. But again, the beauty of all of this is that if you take all of these different attributes and just hyper target on clinical quality, it doesn't matter, right? So sometimes, like for example, some new nurse practitioners are fantastic. They're very good at following the correct treatment algorithms and staying with the treatment algorithm. And then sometimes you get some very experienced clinicians who are not very fantastic, and we say, hey, look, that's not evidence-based prescribing. You got to get a lab, blah, blah, blah. They say, no, I know better. I've been doing this for 20 years. I don't think you know better than science. And so it's actually not what you would expect, where the more years of experience you have in mental health, the better clinician you are in many cases.
Right. I can definitely see that, because it's hard to teach an old dog new tricks, and there's a lot of new tricks out there that old dogs just aren't up to date with.
That's exactly right.
Where the younger students are taught, they don't know any better, right? They're just like, oh, this is, but the data shows, the science shows, the research shows, you follow this process, the patient will get better, right? And if you don't, there's randomized trials to show that it works, and so follow it and it works. So, where you guys are in mental health now, do you expand beyond mental health? Do you go to other diseases and specialties, and where's your next blue ocean?
Yeah, good question. So first of all, mental health is really going to be our bread and butter, and anything we go into will be related to mental health. So first is international expansion. So we are in the UK, which is really has been exciting, and we want to move to other countries as well. The other is that because our quality, again, I sound like a broken record, but because we focus on clinical quality so much, we're actually been chosen by pharmaceutical companies to run clinical trials, to develop new drugs. Right, and usually that's reserved for the large academic hospitals like Harvard and Stanford and the top institutions. But they've chosen us to run trials because we've been able to demonstrate outcomes. So I'm very, very excited about that. We have adjacent programs that are being stood up right now as well. So, for example, I'm very excited about our substance use disorder treatment line. We're going to have child psychiatry in a few months. And the other one that's really fascinating, so we have actually like a nutrition and weight management program, which is very, very dependent on mental health, right? The two are very related. And so, but the idea is that before we move into any of these, we just make sure that we have the best clinicians, the best treatment algorithms, and we go from there.
Right. So you guys are very much disrupting the mental health care space. What is mental health care going to look like in 5 to 10 years?
Yeah, good question. So in 5 to 10 years, I really think telehealth is going to be the modality for outpatient care. Of course, you're going to have a small percentage, maybe 10, 15% of people who prefer to see their therapist or prescriber in person, but really this is going to be the main modality. And and I think what's going to happen is we're going to be able to do much more precision mental health, right? So instead of right now, the way we treat is actually very random. It's a trial and error in terms of medication selection. So when you're depressed, literally, I'm kind of trial and error. I'll start you on Zoloft. Oh, that didn't work. I'll start you on Prozac. Oh, that didn't work.
Yeah.
Let's try. There's no data to drive that. So eventually, I think we're going to be like cardiology, where it's you come in and you have these symptoms, and based on your heart rate, based on your EKG, based on we're going to go down this path because that's where the most evidence is, right? We don't have that right now. We don't do that right now. So I think in a few years, we're finally going to be able to do that. I actually think telehealth will enable that. Right? Because telehealth, we're able to collect much more information on our patients. And so I'm really excited about that. You can think about it this way. Let's say I'm seeing you, Brandon, as a patient. And if we could record this session, right, I could actually probably assess your voice, your mood, the word choice that you're using, things along those lines. That could be predictive of whether you're going to respond to a certain medication or not. Right now, no one's doing that,
right,
and we can do that. So there's a lot of cool stuff that can be done. The data is there. We just have to do it, right? So I'm very excited about what telehealth has been able to do above and beyond just increasing access, but it's really laying the foundation to increase quality as well.
Well, definitely keep using Doxme because we have some things coming down the pipe that is going to be addressing directly the things you were just talking about right there, about using the data, using it to deliver up that data and make use of it in the future. So exciting things. And so David, thank you so much for your time today. This is very enlightening and very fascinating, and appreciated all the words of wisdom that you shared. And thank you for being with us today.
Absolutely. It was a pleasure, Brandon. Thanks for all you do for the space, and best of luck going forward.
Thank you.